A very good morning, ladies and gentlemen, and to everyone who's joined us on the second last day from the biggest virtual implantology event of 2020. My name is Ruben Lobo, and on behalf of Team DentistChannel.Online, I warmly welcome you to the second session from the second last day of the virtual Implant-Expo, rather the world's first virtual Implant-Expo. Ladies and gentlemen, I hope you all have been doing well and you're keeping safe in these unprecedented times of the COVID-19 pandemic or the lockdown. We had a session today. It was a very enlightening session. And once again, we are back with a wonderful speaker, a person who's been practicing implantology since the last 11 years, and a person who's really wonderful at his skills as well as his expertise. Ladies and gentlemen, we have with us Dr. Tanveer Ahmed from the magical city of Dubai. I mean, initially he's of course an Indian by heart, but of course once a person settles down in Dubai, it's always Dubai like the first priority. But jokes aside, yes, India would always be that first place for Dr. Tanveer as well as for everyone, all those proud Indians. So ladies and gentlemen, a short introduction about our speaker, Dr. Tanveer. Dr. Tanveer completed his BDS from the Bangalore University in India. He's a certified implantologist from the German Board of Oral Implantology. He's been practicing, like I said, since the last 11 years. He's a user of multiple implant systems and of course a wonderful personality and a very humble person. Ladies and gentlemen, without much further delay, presenting to you Dr. Tanveer Ahmed live.
Thank you very much for the kind introduction, Ruben. It's wonderful. I'm honored to be here. So there are two things basically I'd like to say. Number one is this presentation is primarily geared towards newbies, new practitioners. I hope more experienced and more seasoned practitioners can also take away a few tips from my experience. I think it's always better to learn from others' mistakes, and we don't have to reinvent the wheel all over again. The second thing I'd like to say is I'm not financially compensated, so I have no personal interest in any of the products that I'm going to speak about. So that's a disclaimer. So this is, like I said, small tips. I think we have amazing speakers and practitioners who've come before me, who are going to come after me, who are going to talk at length about pterygoids and zygomatics and things of that nature. However, I would like to focus on on more simpler day-to-day implants that I think a lot of practitioners are doing every single day, day in and day out. So I like to keep things as simple as possible, as predictable as possible.
Dr. Tanveer, sorry to disturb you. You've not shared your presentation yet.
Yes, I will put that on. Let me just share my screen. There you go. Is that okay, Ruben?
Not yet.
Okay, just give me a second.
Have you shared the screen on Zoom?
Yes, just give me a second. I am doing it. There you go. Have you got it now?
Yes, sir. Slideshow, first presentation.
Yes, give me a second.
All right.
So yes, that's the title. It's basically small tips and tricks for implant placements, and let's get started. So we have basically I've divided into three steps: the pre-surgical steps, the surgical steps, and the post-surgical steps. The first thing about the pre-surgical steps is I'm a big believer in the CBCT. However, I have practiced with and without a CBCT. I've practiced with and without panoramics. So sometimes it used to be one or the other. But now I think after my years of experience, I think each one of these imaging techniques has something to offer. So panoramic is usually what I would recommend everyone to start with, which I think a lot of people are doing already. But make sure that it is a very good panoramic X-ray. It's digital. Do not compromise on the quality, because if it's out of focus, if you're sending it to a center which doesn't have the best machine, then probably it would be a good idea to change your machine, because it's much better to have things in the beginning rather than missing out on, on a lot of information. And this also helps you in your practice as well, because you'll find out other things, such as periodontitis, which might not be visible, as clearly visible on, on an IOPA. And CBCTs, as lovely as they are, because you are not seeing a blended picture and you're seeing slice by slice, sometimes you could end up missing things as well. So start with the panoramic, and then I'd say definitely take a CBCT. I take a CBCT for every single case, regardless of how easy or simple it may seem on the panoramic. Yes, the old techniques were there, such as bone sounding and things of that nature, but nothing is a replacement for the CBCT. You want to have all the information available before you start, because many times when you open up things, you're not ready for what you find inside. That's very obvious. But also for new practitioners, it helps you to lower your inventory, to keep a smaller stock of implants. You don't want to have 50 implants of various sizes, diameters, various manufacturers. You want to have maybe 3 or 4 sizes at most, so you're ready, and you want to keep the most optimum implant size before you start the work. So for example, let's say you're doing a molar. What would be your preferred size? Ruben, can we have a poll?
Unfortunately not, sir. In fact, what we could do is we could ask the participants to answer on a chat box. So we have a chat box, and if you have
fantastic. Okay, so let's make this a little interactive. If you can start a chat box, and maybe I would like to know, this is mainly for newer practitioners. Let's say people who have placed less than 50 implants. What is your preferred size for a molar implant? Can you please type it in the chat box? Let's wait for about 30 seconds.
Yeah, I mean, we can continue, so maybe we can get back to this a little later as well when we come to the discussion.
Very good. Yes. I just wanted to know, very good. So one has responded 4, 4.5, excellent. Okay. Right. Okay. So there are no right or wrong answers here. Yes, you can put a 4mm diameter implant. You can put a 4.5. You can put a 4.3. If you're talking about stronger implants, I would say titanium alloys. We're not talking about pure titanium here, which are stronger. You can even go down to a 3.5. So something like a Straumann Rock Solid. Of course, there are others such as Bicon, which can even handle smaller diameters. But the issue is this: if you are using a 4 or 4.5 diameter implant on a molar, then we have an issue. And the issue is that you have a very small platform. The implant will get integrated. The crown will last for sure. However, you will have a very wide crown on a very thin base. So what this does is you have triangles on both sides, which shows up on X-rays, and your patient is definitely going to ask about that, but that's fine. But if your gum recedes, then you end up with a large gap over there, potential food lodgement. You don't have the best emergence profile. And these are all the issues which you face with smaller diameter implants. And this is why I would recommend you take a CBCT. So if you can, I would say the ideal size would be a 5.5 or a 5. Anything smaller, you are going to compromise on the platform, and you are going to have a crown that looks like a lollipop. So please use the largest diameter that the bone can take. So even a 6 would be good. You have a very nice platform. You have a very nice profile. Of course, do not compromise the basics. Make sure you have adequate buccolingual width, adequate mesiodistal width. Do not go below the 2 millimeter rule of bone all around the implant. So provided you have bone all around, please put in a wider diameter implant for a molar. The same goes for premolars as well. I would say a 4 or a 4.5 is ideal for a premolar. Yes, you can do it with a 3.5 or a 3 millimeter even if you're going again for a stronger alloy, but then you have the same issues. Anyway, so move on. Let's move on to the next step. Okay. Okay. Regarding antibiotics, I hope my experience with antibiotics is I was using it in the beginning, I had stopped using it for some time, and then I started using it again. And the reason for that is the statistics show that there is approximately a 3% higher failure rate without antibiotics. This was as per my last record. Maybe those statistics have changed as of this point. But I think even a 3% is significant, which means that for every 100 implants that you have placed, you will lose 3 implants because of not using antibiotics. So that's a needless risk in my opinion. This is what I do. I always prescribe pre-operative antibiotics, pain medication as well, because I like to have it done pre-surgical, so that for 2 reasons. Number one is it's already in the system by the time the patient has left the surgery. So he's not in a rush because sometimes the patients have had the surgery. They might have to drive back home. Home could be an hour away, it could be 2 hours away. Sometimes they don't, have a pharmacy nearby, or they forget. And then the pain starts and it leaves, a bad taste in the mouth, so to speak. So once they're already pre-drugged, whatever the protocol may be, whether it's diclofenac or ibuprofen, it's much better that they have taken it prior to the procedure rather than later. Same thing goes for antibiotics as well. You can use whatever protocol you like. 2 grams of penicillin prior is what I use, and then we follow up with a week of antibiotics as well. This is something which has come from more senior practitioners. It's a protocol which I have adapted. It saves us a lot of trouble. Like I said, it might not be a very high failure rate, but even 3% does make a difference. Mouthwash is absolutely mandatory. And I always use long-lasting anesthetic. This goes into the surgical phase. Yes, sorry. I always use a longer-lasting anesthetic. I do not use lidocaine much anymore. I used to use a lot of articaine. I don't use that much anymore. I use mepivacaine for all my surgeries because it's longer lasting. We are uninterrupted for about 2 hours. There is no period of time where you have to stop in the middle of the surgery because the patient needs a little bit more anesthetic. It wastes time. It causes stress for the patient as well as for the doctor. The assistants have to take a break. So 1 shot of mepivacaine on the buccal and 1 on the lingual with adrenaline goes for about 2 hours. And I think it's enough for almost all except the most elaborate and advanced procedures. So this is what I use. Okay, a few more. I think I lost 1 slide. Okay. Yes. Okay. Regarding the incisions, a small take-home tip for you guys would be: I always use papilla-sparing incisions. I almost never, ever cut the papilla, even in the most narrow of places, because you are going to, anyway, leave about 1.5 to 2 millimeters distal and mesial. So why would you want to cut, that papilla? If you have to cut the papilla to put the implant in, you would probably using the wrong size of an implant. So that's number one. Number two is it's always better post-operatively. You end up with less bone loss in the spaces between the implant and the tooth. So that's something which I always spare. It also helps us in getting a better implant mesio-distal position. You can thread the implant in a little bit better because when you have spared, let's say 1 millimeter or 1.5 millimeters, both mesial and distally, you have a better point because you're eyeballing most single tooth cases. Since you're eyeballing them, you're not using a surgical stent, your implant placement will also be more accurate. Blade handling. Okay. I use both blades. I use a 15C blade as well as a number 12 blade. I use a 12 blade because you have better access in a narrow spot. You can get up closer. You might have to struggle to get that last 0.5 millimeter out with a regular 15 or a 15C blade. So a 12 blade, particularly in the mesial, where it's a bit difficult to reach because your tooth prevents your blade from going all the way. A 12C blade can actually go and stop just short of where you want to. So you'll have a much better reach. So that is one tip. And second is handling the blade. I just want to show you a video. And I do this with the 15 blade. I jiggle the blade. I move it from side to side, as you can see there. And this jiggling helps us to loosen up the flap. You don't have to use a very aggressive periosteal elevator because sometimes that ends up tearing the flap, and you might spend a lot more time in suturing it, and again, that adds to a lot of stress. So this makes for a much easier release. Second is the use of a high-speed burr, which I always use. So this is the burr I use. This is from a high-speed handpiece. And that's the close-up of what it looks like. So I like to use this for two reasons. Number one, it's much finer than a pilot drill. It's approximately 1 millimeter in diameter. Number one. Number two is it's very easy to control. A pilot drill can only go in a straight line. If you go wrong and your angulation is wrong, which you have to verify with an IOPA, it's very difficult to correct with a pilot drill. So with this sort of a drill, it's much easier to change direction multiple times. And I'm sure a lot of newbies face this issue. You put the drill in, you think it's in the right angle, but then you take an IOPA, it's 20 degrees off, 25 degrees off. So these mid-course corrections are much easier with the Lindemann drill. And why do I use a high speed? I think, again, there might be a concern. We were told not to, keep the speeds beyond 1,200 RPM, 1,500 RPM, 2,000 RPM, whereas a high-speed drill goes at 200,000, 300,000 RPM. The point is that it doesn't matter. It doesn't matter because this is the initial drill. There is no question of any bone necrosis because you are going to take away all the bone that is going to be adjacent to this drill. You're going to follow this up with larger and larger drills. So any bone which potentially, could get overheated is going to be drilled away anyway, regardless. That's number one. And point number two is I really don't think it matters. You're going to use cold saline. Of course, it has to be sterile. which you can control and should be controlling in your water bottle and in your lines as well. So make sure that you have no bacteria in there. And that's clean water, so there's no problem there. And I'm sure a lot of you are using high speeds for wisdom tooth extractions and so far all the time. You are cutting bone with it. So when you cut bone there and you don't have necrosis over there, you're not going to have necrosis for an implant site either. And the third point I'd like to ask about the drills is I do a lot of osteo densification as well. Okay. I do a lot of osteo densification. I am not sure if this video is there. Just give me a minute. Let me pull it out. And there are the Versa drills, which I'm a big fan of. I use them more and more. They are very kind to the bone. They don't drill away. They can be used as traditional drills in a counterclockwise motion to drill away, and they can be used to densify and thicken the bone and move them away from the side in a counterclockwise direction. These are used at approximately 1,200 RPM in a counterclockwise direction. And one of the things that I love about them is you can see in this particular case how thin the bone is on the buccal. If you use conventional drills, this bone actually chips and flakes away and breaks away and makes the subsequent implant positioning much more difficult. When you're osteo densifying, then you preserve that little bit of that little thin crest which you can see, and this really helps in keeping the bone intact and minimizes the amount of bone grafting that you need. Ruben, were you able to see that video? Ruben, are you with me?
Yes, sir. Video is playing. Can you play it again? Yes, sir. Video is playing. Continue. Thank you.
Okay. So this is okay. So these are the Versa drills. And like I said before, these are for osteo densification. They are used in a clockwise or a counterclockwise direction. Counterclockwise is for moving the bone away to the side, and there's no burr chatter. The burr doesn't chatter the way normally most drills do, because the flutes on this are very narrow. Unlike the traditional flutes, which have only maybe 3 flutes or 4 flutes, this has got multiple flutes. So it's a much smoother cutting burr. The cutting experience is much better. So you have better control. The burr never goes out of control. It never breaks away bits and pieces of the bone. So this is something which is really nice. In the second site, which I'm doing over here, I'm also using it in a counterclockwise direction. There you go. So you can see it's extremely kind to the bone. And I'm not sure if you can see it well on this video, but okay, let me pause that. But you can actually see the extremely thin, dense lip of bone around that area. So this is very strong. It doesn't break away when you place the implant. I've had this experience in the first implant that I placed in a similar sort of a situation where the entire cortical blade just broke away. So this is something which almost never ever happens. Of course, you have to know the limitations of the burr as well. It cannot densify or change extremely thick cortical bone. It works very well in cancellous bone. So again, that is where a CBCT helps. you have to check beforehand, before you do this, whether you have a lot of cortical plate or not. If you do have a lot of cortical bone, then this might not be the best idea. And you can still use them in a conventional way and do conventional grafting rather than relying alone on something like this. Okay, so let's stop there. Next point is regarding implant placement depth. Again, I would like the audience to just let me know how deep do you place your implants? How deep from the gingival crest do you place your platform? Is it a millimeter subgingival? Is it 2? Is it 3, 4, 5, 6, more? Does it vary from implant system to implant system? What is the protocol? Can I see this result as well, please, Ruben?
Yes, sir. Certainly. The same thing can be done on the chat box.
Yes. If the participants can just let me know regarding how deep you place your implants, then this will help.
All right, participants, if let us know how deep you've been placing implants in the chat box. So we have a chat box. Please, let's have this as an interactive session and not just one session, a one-way communication. It's more of a interactive session, and let's try to make this the best of its interaction. So please put your comments in the chat box. Thank you.
2 millimeters, 1 to 2 millimeters below the alveolar crest, 2 to 5. Okay, so this is something which I learned recently. Again, the thing is, it does not depend only on the alveolar crest. It also depends on how thick your gingival tissue is. So the rule is 4 millimeters, not 4 millimeters below the crest. It's 4 millimeters below the gum margin. So if your gum is 2 millimeters thick, if the gingival tissue is 2 millimeters thick, then you need to place your implant 2 millimeters deeper. So that's a total of 4. If it's 1 millimeter of gingiva, you need to place your implant platform 3 millimeters subgingival, and so on. And the reason for that is because invariably the biological width will get re-established and you will lose bone. So if you have placed it exactly 1 millimeter below the crest and your gum tissue is only 1 millimeter thick, over a period of time, you can expect to see bone loss over there. So this is something which will save you a lot of trouble. This is not something which affects osseointegration. Your implant will get integrated. If you're lucky and everything is good, your bone levels might be stable. But like I said, I don't like to leave things to chance. And you will have bone loss in the years to come. So you want your implant and your bone levels and your tissue levels, more importantly, to be stable 5 years, 10 years from the time you've placed your implant. And this is something which is going to save you a lot of trouble as well. Okay. Next is bone milling. If you have placed your your implant 2 millimeters subcrestal, and you don't mill the bone around it. You place your cover screw or you place, let's say, a healing abutment. And if you don't check it with an IOPA just because you think you've got a sufficient amount of torque and everything feels good. Again, you're leaving things to chance. You end up with a mess that it's not completely inserted. The healing abutment might engage partially. The torque and the feedback that you get makes it look as if you have engaged it, but actually the bone is preventing it from seating all the way. So in this situation, Um, use a bone mill. Take out a little bit of bone. In fact, not some. I think many implant systems have it. I know Nobel has it. I know Straumann has it. I'm sure some of the others have it as well. What you would want to do is to place your bone milling guide and then use a trephine which comes with it as part of the kit to remove any bone around the collar so that your healing abutments seat completely. Also, this makes your future steps easier. You you'll find it much easier to engage your transfers. You will find it easier for the prosthetics later on. Sometimes you find that you take a transfer and that fits well, but then when you finally get your crown, the crown doesn't go all the way because you have a lot of excess bone on the sides. So yes, that's right. I can see a chat, the total 4 millimeters, that is gingival biotype plus, plus the bone width. Yes, I can see the answers. Yes, crestal bone loss will take place and you place the implant below the crest if you do not have the 4 millimeters of gingival width. If your gum tissue is 4 millimeters already, then you don't need to place the implants subcrestal. You can place it at the crest. If your gingival tissue is 3 millimeters, then you have to place it 1 millimeter subcrestal. Okay, and if your gum tissue is 2 millimeters, then you place it 2 millimeters subcrestal and so on. Of course, there are some implant designs which you have to go subcrestal regardless, such as Bicon, for example. Ankylos is another one, which you can never place crestal. You always have to go subcrestal, but those are the exceptions. For the vast majority of practitioners who use traditional implants, you have to place them according to the 4 millimeter rule. So look at the gingival biotype, and this is where your IOPA is so useful because you cannot predictably check the thickness of the gingiva on a panoramic or on a CBCT. This is why we take all three imaging. We have the IOPA to plan for the gum thickness and also make sure which depth you are placing. The CBCT again helps because let's say you have a 10 millimeter implant, but you don't know if you're going to go 2 millimeter subcrestal. So you have to account for that. So even though it's a 10 millimeter implant, if you're placing it 2 millimeters subcrestally, please account for that extra 2 millimeters and make sure that you don't have any vital structures in those 2 millimeters, such as your sinus or your inferior alveolar nerve, any of these things. So that is something which you have to account for. Okay. I wanted to add a note on surgical stents. Surgical stents is something which I am not a big fan of. I use them if I'm doing multiple implants in full mouth cases. I don't like to rely on them completely. I don't trust them primarily because I have used a number of them. And I find that there is a lot of play in many of them. There is a lot of space, so you can actually angulate the burr in multiple directions. So you can almost have an error of about, I would say, 10 degrees easily. And the most accurate ones around 5 degrees. So this is quite significant. If you're placing implants very close together, you can end up with an issue where you might be having an implant to implant contact, or you might be going into vital structures, or you might be hitting the nerve or the teeth adjacent to your implant sites. So use them as a guide. Use them as a guide. They're definitely useful, but don't rely on them 100%. it should not be a substitute for common sense, and it should not be a substitute, for taking adequate precautions and thinking out of the box. Always double check and triple check your angulations, even if you have the stent, to make sure you know where it is. One of the beginner mistakes that I have done is we take a lot of care during the initial drill. The first drill, you make sure everything is perfectly aligned, the drills come out well, and then the subsequent drills, let's say the second drill that you go about, let's say, a millimeter off or half millimeter off. The second drill goes a millimeter and a half off. The third drill goes 2 to 2.5 millimeters off, and the final drill is almost maybe 3.5, 4 millimeters off. And then when you place your implant and you take the final X-ray, it's in a completely different position to where you started. So please check the angulation at every single drill, not only the pilot drill, not only the first drill. Make sure that you keep the prosthesis in mind. I like to do screw retained restorations almost exclusively. We don't do as many cement retained restorations as we used to. I think the whole world is moving away from them. So the way you should be thinking is, where is going to be my screw access hole? You are going to place your drill through that screw access hole every single time. Every single drill goes through that screw access hole. It starts from the first drill, second drill, third drill, and final drill. It doesn't matter which system you use. If you're using a single implant, and we're not talking about an extremely angulated case with a lot of bone loss where you have to put your implant in a slightly non-traditional position. You always want to have the screw hole bang in the center in any posterior tooth, whether it's a premolar or a molar. If you're talking about an incisor, then it has to, or an anterior tooth, it has to come out from the cingulum area, slightly lingual or slightly palatal. So keep that in mind. That is where your drills should be. Not only the first drill, every single drill should be through that screw access hole. So keep this in mind every subsequent drill that you place. There is a quick question saying, how do you check the thickness of the gingiva? You check the thickness of the gingiva using the IOPA X-ray. A perio probe can be misleading because you could put it at the wrong angle. Sometimes perio probes can actually go through very soft bone. Sometimes your bone has porosities, it's irregular, such as the video where I just showed you. Let's go back to that. So in the distal implant side, we have a lot of I'm so sorry, it's not this. Please bear with me. I'm so sorry. I think that part of the step is missing. But let me just see if it should be here. 1 second, please.
Yes, Dr. Tanveer, you need some help?
No, I'm fine. Just give me a second. I'm just trying to find the appropriate video. I'm sorry. Yes, I think I've got it. Okay, we can start screen sharing again. Okay, so are you able to see the screen now?
No, sir, we cannot see the screen.
Okay, let me just enable the screen sharing again. Is that fine now?
Yeah.
Okay, so in this sort of an area, if you use a periodontal probe, you will be unable to get the exact thickness, because you can put your probe here, you will get a completely different reading versus over there versus over there. So never use a periodontal probe for checking the gum thickness unless it's a completely healed site. It can give you very erratic readings. So try to use a combination of an IOP and CBCT. You want to do this in the pre-surgical phase, not during the surgery. So you have to place it 2.5 millimeters below that, okay, below the crest, which is over here, not over there. And the rest of the area, you will have to graft. Okay, and there is a last step which I would like to show. And that is the bone milling step. The bone milling again is very important because that's my high speed drill again. And this is from Nobel. And that's your implant. And we check that it is 4 millimeters from the crest. And this is what we find. We cannot insert a healing abutment completely all the way because the bone is coming in the way. Always, and this is another tip for newbies again, always try and hold from the end all the components, so nothing slips off, nothing falls off. Your angle is absolutely right. You get better guidance, you get better angulation. Your implant doesn't go in another direction, particularly if you're working with soft bone. So this is the bone milling guide. It is not a gingival former. It's not a healing abutment. It is something over which a trephine is customized. So it actually goes in around it and it mills all the excess bone which might potentially come in the way of your healing abutment or your transfers. So you don't have to do this. You can do it using a round burr, for example, a round diamond. But this makes it much easier, and you don't overcut and you do not damage the implant platform. If you're doing it blindly with a burr, then there is a risk that you might be damaging the platform, and that's a mess because you will never have a close fit of your abutment if you damage the platform, and that will create complications later on. So try to get one of these. Make sure that your implant system has one of these. This will save you a lot of trouble, in the years to come. Okay, and the last step, I wanted to show you a short video on suturing. I think if there's any questions. Newer innovations like zirconia crown or other newer implants. I think you're talking about zirconia implants, Dr. Mabel, maybe? Because zirconia crown is technically not a new innovation. I don't have much experience with zirconia implants, so I would not like to speak about them. Yes. Okay. Just please give me one last minute. I just would like to share a short video. I'm so sorry. I think just 1 second, please. No, I'm so sorry. I cannot find it. Regarding the post-surgical, let's move on to the next step. Post-surgically, I would like to say always check with your patient on how they're feeling. I always make sure that I call the patient personally. Do not have your receptionist call the patient. Always check on them personally, because sometimes patients do not convey the right information, or it becomes like a Chinese whisper. They say something, the receptionist thinks something else, says something to you. So I would say call the patient directly. So this is going to help you in case something goes wrong. In case sometimes there are patients where they might be experiencing a lot of swelling, and they think it's normal, so they haven't taken anything, they have not taken any medication. So this is your time to step up and possibly increase or modify your medication protocol. Please use corticosteroids. There are indications for it. Do not be scared of using a mild corticosteroid. My protocol is using prednisolone, 20 milligrams, in case of any sort of grafting, because you normally don't see much swelling in simple routine cases if you have followed protocols. But if you have used bone grafting, particularly xenografts and membranes, you will see a lot of swelling. So this is where prednisolone and other corticosteroids come in. You will see that it really helps, either prednisolone or hydrocortisone, bitmethasone, anything. It helps in reducing the swelling. It is also an extremely potent painkiller, much better than ibuprofen or diclofenac or any of these over-the-counter medications. And it goes a long way in keeping the patients comfortable. So corticosteroids are absolutely indicated in cases where we use xenografts. Of course, I'm moving away from xenografts now. I do use them particularly in anterior cases where I need to make sure that the bone levels are extremely stable. And xenografts are good for that because they do not resorb. But in the routine cases where we just need a small amount of augmentation, for alloplasts, my go-to is something called ethos. It's TCP, tricalcium phosphate, with the calcium sulfate as a barrier. It does not require a second membrane. It saves a lot of time. Again, as new practitioners, where they take a lot of time in grafting, and grafts, particularly xenografts, can get infected quite easily. And then it's a mess because you end up removing the graft, you have to end up removing the membrane and so on. Alloplasts will save you from a lot of this. The biological reaction, the host reaction to alloplasts is much kinder than it is to xenografts. And if you have not used it, I would suggest you use something similar. I think EasyGraft is also another option, although I've just used it once. Honestly, I don't know too much about it, but Ethos has worked quite well in my hands. But Again, if it's a large volume augmentation, then I would prefer xenografts. I think that's about it. That's all I would like to say. And I'm just going to stop now for the question and answers, and we'll take your questions.
Yeah, the first question, subgingival placement of implant should be minimum 4 mm. What's the maximum limit? If it's too deep, may give hygiene issues.
No, 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 no. I'm so sorry. I'm sorry if you have misunderstood. I did not say that it has to be 4 millimeters subcrestal. It has to be 4 millimeters from the gingival crest. So I'm repeating this again. If the gingiva is 2 millimeters thick, then it is going to be 2 millimeters subcrestal. So the total width is 4 millimeters. The total distance from the gingival crest to the platform, implant platform, is 4 millimeters. So you have to do your math. If the gingiva is 1 millimeter, as you check on the IOPA, then please go 3 millimeters deeper. And if you are going 2 millimeters of thickness, then you have to go 2 millimeters deeper. If the gingiva is 3 millimeters thick, you're going to go 1 millimeter. And if the gingiva is 4 millimeters thick, you are placing it at the crest. I hope that's clear.
Thank you. I think you've covered this question, sir, from Dr. Mabel. Your thought about conventional implant. You advise that to place all the new innovations like zirconia crown or other new implants.
That's right. Already covered.
We move to the next question. Which suture do you use for closure and why?
My go-to is Vicryl. That's what I use primarily. I prefer that because it handles well. It keeps knots quite stable. It's relatively clean. Monofilaments are cleaner. Teflon, for example, is PTFE sutures are also very nice. The problem with PTFE sutures, which I found, is they're so clean that sometimes the gum grows over them, and they're non-resorbable. So taking them out sometimes become an issue if your patient cannot come back for whatever reason. Or if they're delayed, if they cannot come back and they come 15 days, 20 days late, then it can actually get buried and it becomes an issue to take them out. Vicryl, on the other hand, is resorbable. So if you cannot take it out, by the 14th day, it's gone by itself. Although I don't keep them for 14 days, I keep them only for about 7 days. And if it's a very large surgical site, then I keep them for approximately 10 days max. I don't use silk. I think it's attracts a lot of plaque. So I prefer not to use it. Nylon is very difficult to tie. Catgut is sometimes falls off by the 3rd or 4th day. It gets resolved very quickly. So that's not my preference. I think I've covered pretty much all the suture materials. So that's my preference. I also like 4-0 sutures, but if it's a very fine case or an anterior case or the gingival biotype is very thin, I would prefer to use 6-0. Of course, with use magnification, you cannot, I mean, it's to do it without magnification. It's a little difficult to handle. So please use smaller sutures. You will find that your results are better. You have less gingiva tearing. The handling is better. The healing is much better as well.
Thank you. Which bone graft is better? Is it xenograft or allograft, or the combination of bone scrapping and xenograft?
There is no better or worse. It honestly depends on the situation. I use xenograft when, like I said, on anterior cases where I absolutely do not want to have any kind of bone loss, even in terms of contouring. because it's aesthetic. So that's something where a patient might complain that, yes, the tooth looks fine, the crown looks good, but I don't like the way the gum looks. So in these cases, I would always prefer using xenografts over anything else, because they're highly stable. You don't lose them after 10 years, 15 years, even a lifetime. My protocol is to, it honestly depends. If the implant is exposed, let's say 2 threads are exposed on the buccal face, then I would use a combination of a xenograph with autogenous bone, usually harvested during the drilling process itself. So you can do slow drilling if required. Of course, this again, you have to check when you're doing the CBCT. So if you know that you have limited bone available, then do slow drilling instead of the conventional 1000, 1200 or 800 RPM. You can go slowly at 50 RPM. This is the Bicon protocol. You can harvest this autogenous bone, keep it aside in saline. When you place your implant, you take a combination of this autogenous bone, mix it 50-50 with xenograft, hydrate it, place the first layer on the implant face. The second layer is a xenograft only, cover with a collagen membrane, and you're good to go. If you want to add a little bit of bone, but the gingival threads are not exposed, you have autogenous bone, like in the case which I showed you in the video. In these cases, you don't need to use the 50-50 mix, because you already have a layer of autogenous bone. You can just place xenograft only, of course, with xenograft. Make a few punch holes on the buccal wall to induce bleeding. It helps in the angiogenesis, lets the blood grow, and you get faster integration of the graft. And always cover with the collagen membrane. I like PRF, but I wouldn't rely on PRF alone to cover xenografts, unless you have a lot of autogenous bone and you are doing a very minimal amount of contouring. In these cases, you can use PRF instead of membrane.
Thank you, sir. Last question. Please provide the name of the systems that provide bone guides.
I know Nobel does it. I know Straumann has it. I'm not sure about the other implant systems. You'll have to check with your manufacturer whether they have these particular systems available. These are particularly useful if you're doing full arch cases and you're tilting implants or placing them at angles. Then invariably you have to use them. It's mandatory.